Hello everyone and welcome to Carpal Tunnel Release Lecture. This is a hand surgery. Specialty is orthopedics, neurosurgery, or plastic and reconstructive. All three of those specialties can perform this surgery, so it depends on your doctor as to which surgery we will be, or which specialty we'll be putting it under. The definition of a carpal tunnel is we are going to excise the flexor retinaculum of the wrist. The flexor retinaculum is also called the transverse carpal ligament, so just know we're talking about the same thing when we talk about those two. The surgical anatomy and physiology, we have the median nerve. The median nerve is the nerve being compressed. Being compressed during the nerve being compressed by the transverse carpal ligament, which then affects the function of the fingers. Surgical anatomy also includes the flexor retinaculum or the transverse carpal ligament. The radial artery runs right next to the median nerve. The synovium, which is the tissue that wraps around the median nerve. And physiology, what does the median nerve do? It is the major nerve going into the hand, both sensory and motor function for the thumb, first finger, and half of the long finger. And so you'll get tingling numbness in those fingers as well as loss of motion over time. So here's a picture of our anatomy. This is our transverse carpal ligament or our flexor retinaculum, whichever way you can think about it best. Our median nerve runs right here. Radial artery comes right here. Our flexor tendons are here. As you can see, the nerve branches off and goes over to these areas. But this nerve is really huge coming into here, and so is this artery, and they usually lay right next to each other, and this tendon kind of sits underneath them in our surgical anatomy. The other nerve we need to pay attention to is the ulnar nerve, which runs here, and it innervates the medial part of the anatomy when we're looking at our anatomical position man, which means our pinky, ring finger, and half of the long finger. So just know your nerves and which artery you need to pay attention to. So why are we doing this? Carpal tunnel syndrome is a compression of the median nerve at the wrist. So that flexor retinaculum is squeezing down on that median nerve and not allowing it to move freely and causing it to be inflamed. What kind of things do we do to diagnose this? An H&P, and for certain patients we'll actually get an electromyography, which is a test where we hook electrodes to the hand and we see how fast the electrical impulses come from the brain to the hand, and if they're slowed we know that the median nerve is being compressed. What kind of special considerations need to be taken into account? The fact that we have several different specialties that we can be working on this patient. Know that in the 90s we tried to do endoscopic carpal tunnel releases. It fell out of favor just because there were greater risks, no better healing result, and the incision was about the same size as what we do just for an open procedure. Any special equipment, we're going to need a tourniquet and we're going to need a hand table that hooks to our bed so we have more room to operate. We're also going to be sitting for this procedure, so we need sitting stools. Our instrument set, we need a hand or a plastic set. Special supplies, we're going to need a needle tip for the ESU or a bipolar bovie. We're going to need an S-mark bandage to exsanguinate the limb before we begin surgery. Medications on our back table, 1% lidocaine to allow some pain relief post-operatively, and some Depomedrol or another steroid that we can dribble onto the nerve to help it reduce the inflammation. All right, what kind of anesthesia can we use? Honestly, we can use every kind of anesthesia. We can use just plain local. We can do local with a MAC. We can do regional, such as a beer block, and we can do general anesthesia. It depends on the patient, the surgeon, and of course the patient's comorbidities. Positioning equipment, what do we need? Well, we're going to be supine with an operating hand table sticking out, so we need all of our usual padding of bony prominences. Our prep, we're going to use a betadine prep and betadine scrub and paint just because we are working on a nerve, so we don't want the chlorhexidine to get into our nerve. We're going to prep the entire hand and the arm circumferential up until the tourniquet, which is usually up on the humerus. So we have quite a big prep area. Draping, we're going to put a down sheet first. Then we can either take a tourniquet towel, wrap around the tourniquet with a sterile blue towel and clip it, or we can use a U-drape, and then we'll put the extremity sheet over the top of that. Our incision is going to be the palmar surface of the hand at the wrist. Procedure steps, this is pretty easy procedure. IHDR, we're going to identify that transverse carpal ligament, and we're going to transect it. And then we're going to take out any inflamed synovium around our nerve, and then we're going to irrigate, hemostase, close, count, and dress. All right, counts. We don't need to perform any instrument counts, so we're going to have an initial count of sponges and sharps, a final closing count of sponges and sharps. Dressing for this, we're usually going to do a daptic or Xeroform 4x4s, and then maybe a cling, some fluffs maybe, ACE bandage, or a possible splint. So we really just want to make sure that this is well protected because it is on a hand, and we're going to hopefully immobilize it either with the ACE bandage or with the splint, depends on the surgeon. We don't usually have a specimen with this procedure. Post-op, our patients are going to outpatient and they will be discharged the same day. Prognosis is excellent once you have this procedure done. Usually it clears up your pain right away and allows for the patient to be pain-free. Complications from this procedure are usual of bleeding infection. We need to make sure that we don't damage that median nerve that we're releasing or the radial artery that runs right next to it. Our wound class is clean for this procedure. And then if you have any questions, of course, please reach out to me and give me a call. Check out these web links. They're great. I hope you all have a great day.